Thanks, Marianne, and welcome everybody. I'm pleased to get a chance to introduce our two speakers today, and following the IOM tradition, they're going to be very brief introductions because their biographs are in the back of the manual in here. And I'd ask people to read them so they can use as much time as possible for their presentations. The theme in this one is where are we in terms of the research agenda? Addressing issues particularly around parenting and other interventions that can be used in primary care. It's critical from what we talked about last time about the U.S. Preventive Services Task Force. They have to have something actionable to read to be able to see what the status of the quality of the work is and the scientific work. Ultimately, we do want to use evidence-based interventions and put them in place in here to help and promote the kids' well-being and prevent a wide range of mental health, substance abuse, and other outcomes for kids. So I'm going to ask the two speakers to come up. Actually, I guess we could probably have you speak from here. That probably is either. Our first speaker is going to be Joan Sardo, who is the professor of psychiatry and biobehavioral sciences at UCLA Medical School. And she's going to be talking about a meta-analysis for integrated data sets, integrated programs for primary care.
Good morning. I want to thank Marianne and the forum group for inviting me today. And yes, I am Jonah Sardo. And as Hendrik said, I'm at UCLA. And at UCLA, I run a depression and suicide prevention program where I do both research and direct clinical work with kids. So I come to the whole area of integrated primary medical and behavioral health care with that very special perspective. And what I'm going to do today is talk about integrated primary medical and behavioral health care and ask the question of whether that provides a solution for us for both preventing and addressing the behavioral health needs of our kids and families. And I'm technologically challenged, so bear with me. So I guess I use this, right? Okay. So my specific presentation goals are to first briefly review the background on why behavioral health is a problem in primary care, which was talked about yesterday, so I'm going to be very brief. And then I'm going to turn to the science and the data and ask the question, does integrating primary medical and behavioral health care offer a solution to that problem? And then I'm going to turn to next steps. And as you all know, behavioral health refers to mental health, substance use problems, and other health risk behaviors. So yes, behavioral health problems are common in primary care. Kids and adolescents with behavioral health problems are often seen in your primary care clinic settings. There's lots of pediatricians in here, right, and other kinds of physicians who see these kids. There also are high utilizers. There are kids who keep coming back with stomachs and headaches, and so they're very frequent in our clinics, and they're likely to have other medical comorbidities. So the brain and the mental condition and health are intricately related in our kids and our adults, and even me, you, all of us, right? Effective treatment for behavioral health problems is absolutely critical for reducing premature death. If you take a look at our leading causes of death by age group in the U.S. for 2013, you can see that suicide is the leading cause of death for adolescents as well as for young adults, the second leading cause of death, and in our 10 to 14-year-olds, it's our third leading cause of death. And suicide, as you all know, is associated with behavioral health problems, and it's often considered a complication of untreated or undertreated behavioral health problems or ineffectively treated behavioral health problems. I put this slide in. These are data that show the rates of self-inflicted injury by age and sex. Is there a pointer here? Well, I probably wouldn't be able to use it anyway. But, but what I wanted to point out here is that if you look at the rates of self-inflicted injury, and that includes suicide attempts, and the orange bars are girls and the blue or turquoise bars are boys. And the rates are particularly high in girls, but they go up between 10 and 14 and then hit a peak in adolescence. So we really need to intervene in childhood and adolescence. It's absolutely critical. It's too late if we come in adulthood. I mean, we can help some people, but we're going to miss a lot of people who need help and who we could have saved or reduced their misery and suffering. The other thing, this is from one of my primary care studies, is that behavioral health problems are associated with other health risk behaviors that are associated with morbidity and mortality. And the blue bars are kids with depressive disorders, and the red bars are kids without depressive disorders, drawn from primary care clinics. And you can see that there are elevated rates of substance use, risky sex, and smoking, all of which are associated with poor health outcomes. We also found that the depressed kids tend to have multiple risk behaviors. So they have an accumulation of risk that's going to affect their health and behavioral health throughout their lifetime. So we really need to get in there with our kids. So then to address this question, we turned to the science, and we conducted a systematic meta-analysis of we searched all of the databases that we could think of between January 1960 and June 2014 for randomized controlled trials that were published in English peer-reviewed journals. And we looked for trials that compared integrated behavioral health services in primary care versus treatment as usual, allowing for some enhancements. We defined integrated care quite broadly to refer to behavioral health care that was provided through primary care services. And that included a range of diverse models like those that were talked about yesterday, the psychiatric consultation model, the collaborative care model, co-located models. It included all of that. Now I'm strayed, huh? and as I said, we looked at comparator conditions that approximated usual care with some enhancements, like referral and feedback on screening. And we looked for key search terms, and then we also included kids who were transitional age youth up to age 21 if the sample was predominantly adolescents and kids. And that's because in adolescent medicine, they go up often to 25. Through our search, we identified 31 studies for a total of 13,129 participants. And in these trials, we found 23 that evaluated treatments for kids with identified problems. So it didn't have to be disorder, but it had to be high levels of problems. So in our study, in the Youth Partners in Care trial, we looked at kids with elevated depressive symptoms as well as kids who had clear depressive disorder. 19 of the trials looked at mental health treatments, and 4 looked at substance use treatments. And then we identified 9 preventive trials. 3 looking at mental health prevention, and here we had more substance use prevention, 6 of them. We did the analysis using comprehensive meta-analysis. We specified a random effects model because we expected and saw significant heterogeneity among the studies. We used raw data whenever we could, otherwise we used the data that was available. And we looked at behavioral health outcomes, not process of care. We wanted to know, did kids get better? That's the bottom line, right? We used the primary outcomes that were identified in the studies, and if they weren't identified or they didn't identify a clear primary outcome, we used the mean of the targeted mental health outcomes or an impairment rating. And we interpreted effect sizes of 0.3, 0.5, and 0.7 as small, medium, and large, respectively. And here's the data. So this is the first cut. And here we ask the question, looking across all of these diverse studies, does integrating behavioral health care with primary medical care make a difference? The answer is yes, it makes a significant difference, and the effect is a small one. Now, if you look at those red squares, those are the studies that in the meta-analysis continued to be significant. So you can see there's variation. Now we're going to pick apart the variation. The first question we asked was, do trial outcomes differ for trials that evaluated treatment? Those are trials that targeted disorder or high levels of depressive or high levels of symptoms as compared to trials that focused on prevention. And in those trials, we included cases where they had high levels of symptoms, but then excluded them if they met disorder, like the Ben Voorhees study. And what we found here is that there was a significant moderator effect for trial type, with treatment trials having a small to medium effect of 0.42 and a weaker effect for prevention trials. And if you look at that, again, you can see there's more red squares. So more of the trials are significant, an overall effect of 0.44, but again, significant heterogeneity in the effect across the trials. And, you know, if you look over here, this is the overall effect above, close to 1, and but you can see all that variation. You get over here with bigger effect. So then we looked at the prevention trials. And while the overall effect wasn't significant, the Ph.D. study, which looked at smoking cessation, did have a significant effect. So there's a signal for prevention. It's just if you look overall, it wasn't as strong. And the Ph.D. trial was quite evidence-based. It used a practice-based intervention using the 5A model, which is ask, advise, assess, assist, and arrange, delivered by the primary care provider, followed by 1 visit and 4 telephone calls by peer counselors. And one of the things that we couldn't quite demonstrate, well, I'll tell you about it later. I don't want to give it all away. Okay. Okay. So the next question we asked was, do trial outcomes differ for trials evaluating treatments for mental health versus substance use problems, right? Well, here we found that there was a significant effect for mental health trials and a weaker effect for substance use trials, and a marginal effect in the moderator analysis of 0.09. And taking a look at that effect, again, you can see there's even more red boxes. Fewer trials have no red boxes. And so that's mental health. And I should say that we also did a sub-analysis looking at whether it made a difference if they targeted emotional problems like depression and anxiety as compared to behavioral problems. And we found no difference, but there was a effect of 0.71 for depression and anxiety versus 0.51 for behavior problems. But again, there's enormous heterogeneity in these studies. But there's a signal here. When we integrate behavioral health care in primary medical care, our kids overall get better. And then if you look at the substance use treatment, again, it's that Ph.D. trial that holds up with smoking cessation. But I should also say that when you look at individual studies, the effect in the reported studies is often higher than it is in the meta-analysis because of the weighting that happens in the meta-analysis and the fact that there's no covariates in the analysis. So this really has to be viewed as a broad look at what happens and going back to the individual trials to really tease it apart. So then we asked, do trial outcomes differ for trials using different integrated care models? And the obvious one is collaborative care, which is Wayne Caton's model. It's the model we used in the Youth Partners in Care trial and in the Impact trial and in Laura Richardson's recent Rhodes study, where everybody was working together. And I'll talk more about that, collaborating to provide optimal evidence-based care for the kids. And here we don't have a significant effect, and we have an effect for both conditions, basically. Collaborative care had an effect size of 0.63. The other interventions grouped together had an effect size of 0.40. We tried to tease apart the other interventions, but really they were so diverse that I didn't feel comfortable, so I lumped them together. Some of them are trials where they enhanced the primary care provider as a resource. And believe it or not, I think that was more effective than my little view of it than the co-located care interventions and all, which is something that, having done collaborative care, I actually really resonate with because kids like their primary care doctors. They feel like they're going to get better there. And the more we can do to really do team-based care and really help the primary care provider to work with the kid better, I think we have a better outcome, at least, but I can't support that with the science, so I probably shouldn't have said it. Okay, so here's the collaborative care trials, and if you look here, there's 5 trials. 4 of the 5 had significant effects in the meta-analysis, and the one trial that didn't is Greg Clark's study, and I I was involved a little bit with that one, and I'll say that I think the reason they had a weaker effect there is that they had a very strong comparison group. They were comparing collaborative care in an integrated clinic where they were supporting both cognitive behavior therapy and optimal medication management with optimal medication management as usual. So I think that they had a very high bar there, and they had a marginal effect in their analysis. And if you look at the other models, again, there's variation, but there's definitely an effect there. So the bottom line is it looks from this analysis like integrated primary medical and behavioral health care provides at least part of the solution for addressing the behavioral health needs of our kids. We're seeing small to medium effects, so there's certainly room to improve things, but the probability is 66% that a randomly selected kid would have a better outcome after receiving integrated care than a randomly selected kid after usual care. Good news. So what next? Well, the big variation in effects across study just calls for us to take a look at what the most promising models are for integration. And I'll just put up here briefly the Agency for Healthcare Research and Quality model for looking at integration and how that links to process of care. And as you can see, it begins with systematic screening, which leads to identification of mental health problems in the primary care setting. You also have integrated providers with co-location, systematic communication, shared medical records, everybody working together to help the kid to feel better or to not develop problems. And then primary care providers or primary care mental health teams become aware of the problem. They feel comfortable treating these kids and coordinating care for them, which is no small feat, because what the average visit is, what is it these days, guys, 10 to 15 minutes, right? What can you do in 10 to 15 minutes? You can't even screen for everything that's listed. And then you have a service of integrated care with patients getting access to care in a setting where they don't feel so stigmatized, they feel engaged in care, and you have increased adherence because you have the ability to monitor. My favorite story for the Youth Partners in Care trial was when we were training the primary care providers, and Gay Carlson was doing the training with me, and she says, well, you know, we have a really big problem getting the kids to come back. And the primary care provider who is leading the team gets up and says, oh, no, we don't. I just walk in and say, I need to see you in 2 weeks for your acne, and they all come back. I'm like, that's why we need to work together. So to give you a sense of what the collaborative care model looks like for those of you who haven't, this is from the Youth Partners in Care trial. And the way it felt if you were a patient or a parent of a patient was your kid went in for a regular visit. They were then screened for depression symptoms, and these were in the days before everything was computerized. And even when it was, I have to say some of our sites preferred paper and pencil and our kids. They were then referred to the care manager. The care manager contacted the primary care provider. Remember, it is a collaborative care. They were briefed. They talked about how to approach the patient and what the patient's needs were. The patient was then contacted by the care manager who said, I'm working with your doctor, and your doctor cares about all of you. So he or she would really like you to come in so we can talk about how your life is going and just make sure you have all the help you can get. We then came in, we handed the patient a little booklet called Stress in Your Mood, talked about every teenager has stress. What are yours? If you're stressed, sometimes you have these kinds of problems. You have any of these? Oh, well, these sound like maybe you're feeling depressed. Oh, really? Well, there's ways of helping with depression. Let me tell you what they are. And so we went through patient education, patient activation, helped the patient and the family pick the kinds of treatments that they wanted, then went back to the primary care provider, grabbed them in the hall or called them or whatever it was at the different sites, talked about what the patient wanted, what the patient's condition was, came up with a shared treatment plan, considered whether specialty mental health consultation was needed. And that's really an important point because our primary care doctors oftentimes feel they need that, and they should have it if they need it. We don't want kids to die because somebody's missed something. And, you know, the thing working with depression, you realize, is that it's a potentially fatal disease. Then the patient and the parents would come in. You do a final education session, finalize the treatment plan, either with the care manager and primary care provider together, or the primary care provider, depending on the site and the family and kid. They would then either get psychotherapy, which was the most common choice among all of our patients. We've written about this, and this was also true in the Clark study. And so they either got cognitive behavior therapy, medication, or some combination, or some people just wanted to wait. Yeah, I'm depressed, but so are all my friends, and I like the way I feel. I mean, it's okay. I don't want to, I don't want you to change the way I feel. So then we monitored them with watchful waiting, and they came back or were called. We did a lot of telephone work to see how they were doing, and we'd make changes in a stepped care model. We had a stepped care model, so that's the way collaborative care feels. And there's other models like people talked about yesterday. There's co-located care. There's technology enhanced care. There's the behavioral health consultation like the Massachusetts Child Psychiatry Access Project, coordinated care, other forms of integrated care. We need to understand what models are best. And you know what? It may vary by setting, obviously, right? Sometimes you may not need the full model. So here's a list of the kinds of problems that we run into. So for example, primary care providers feel ill-prepared, and here's some possible solutions: to train, to consult, to have resource material. And here's the other kinds of problems that we have in primary care: inadequate resources. Well, in collaborative care, having the care manager there working with a team helps. You can have a better referral network, information system to support linkage. The other big problem in primary care is quality of care problems, particularly inadequate follow-up and treatment exposure. So again, the care manager was critical there, and creativity, such as telling the kid to come back for their acne. Co-location improves access enormously just because they're there together. And another one of my favorite youth partners in care trials was, I was one of the care managers. I'm always one of the clinicians in every trial I do, so I understand it. And I'm walking with a kid, and we had gone outside to get a drink or something, and he looks at me and he goes, "Where is your office?" I said, "Why do you ask?" He said, "Well, your office is there with my doctor, right? It's not over there where my office really was, where all the nuts are seen." And so, there really is something for co-located service. And the other thing that I think is really important, and it's really important in relation to prevention, the whole prevention issues, is that most of the problems that we deal with, whether they're health-related behaviors or disorders, are episodic. So if you treat a disorder like depression or a suicidal episode, you're seeing the kid then, but they need a good monitoring system. They can't pull out of the system because to go to the suicidal kids, something happens. They could look wonderful when they're leaving your office, and something happens, and the kid who looked wonderful has this huge surge of emotion and cannot cope. So you really need primary care monitoring these kids, and you need a primary care system where you have accessibility 24/7 if a kid has problems. So I think that we need to have a chronic care model, or I don't know if we should call it chronic care versus maybe lifespan. Maybe there's a better language, a continuous model. So what are our next steps? We have to get effective integrated care models once we figure out which the best ones are into routine practice in real world settings. And we have to ensure rigorous scientific evaluation to inform practice and science in a continuous quality improvement loop. So the other big issue is costs, right? I mean, costs are absolutely critical. If we don't understand the costs of our services and integrating care, we probably won't have it implemented. That was talked about a lot yesterday. And to address, so we had a project that was funded by the APA that involved the Society for Clinical Child and Adolescent Psychology, the Society for Child and Family Policy and Practice, which Marianne is the president of, and the Society of Pediatric Psychology with APA, that was designed to optimize the success of healthcare transformation through science. And through that project, we came together as a broader group with the American Academy of Child and Adolescent Psychiatry, the American Academy of Pediatrics, and the Society of Developmental and Behavioral Pediatrics. Terry, are you here? Yay! And the Milliman Group. And we're involved in a project right now to estimate healthcare savings opportunities with integrated medical behavioral health care. And we hope to have that data in the not too distant future. So just to summarize briefly, behavioral health is a problem and it can be addressed through primary care. Our evidence, what it isn't large, but it is substantive, indicates that integrated primary medical and behavioral health care can offer part of the solution. But we've got some steps ahead of us. We have to clarify the models and service components that are associated with the greatest benefits and feasible across our diverse settings. We have to find ways to implement effective models in practice, and we desperately need to have rigorous evaluation and a continuous quality improvement process to improve the care and practice settings. The longer I live, the more I realize that we have to track our outcomes. It's probably the most critical thing we do and make evidence-based decisions in clinical care. Thank you.